you to tonight's Hipec Facebook Live presentation titled Utilization of Hipec for Gastrointestinal Peritoneal Metastases. Our presenting surgeon is Dr. Zachary Brown, Assistant Professor of Surgery, Surgical Oncology and Regional Therapies at NYU Long Island School of Medicine. Dr. Brown has a special interest in treating patients with advanced or metastatic cancers originating from the appendix, colon, rectum, small intestine, stomach, and peritoneal surfaces. As a board-certified surgical oncologist, he is an expert in treating patients with a known method as cytoreductive surgery and hyperthermic intraperitoneal chemotherapy. My name is Glenn Keeley. I will be your event moderator. During Dr. Brown's presentation, you will be able to message your questions, which will be answered following Dr. Brown's presentation. At this time, from NYU Long Island, I would like to welcome Dr. Zachary Brown.
All right, thank you so much for the introduction. I'm going to go ahead and we're going to get started. So what we're going to be talking about today is we're going to talk about the utilization of Hipec, also known, like Glenn said, as hyperthermic intraperitoneal chemotherapy for patients with gastrointestinal peritoneal metastasis. Here are my disclosures. And this is what we're going to be talking about today. So we're going to talk briefly about what are peritoneal surface malignancies and kind of set the table on where to go from there. And then basically, what are our treatment options? How do we get here over the course of time? And really, who are candidates for this operation and why do we do surgery for it? So that's kind of what we're going to be talking about this afternoon. So what are peritoneal surface malignancies? So peritoneal surface malignancies are also, you can hear of as peritoneal carcinomatosis. So it's when the tumor involves the peritoneum or the lining of the abdominal wall and has spread throughout that space. Now that really encompasses a wide variety or wide range of cancers. So you can get primary peritoneal cancers, which come from the lining of the abdominal wall, the peritoneum. Now these are very rare. And these you hear of basically is mesothelioma, which you hear about a lot on the news, desmoplastic small round cell tumors, and also you can get primary peritoneal serous papillary carcinoma. But also what you can get are secondary or metastatic disease that comes from somewhere else that has spread to the wall of the abdomen. And these are really not so rare. So we think about mostly our cancers of the appendix, colorectal origin, gastric cancer, and also ovarian. So this afternoon, what we're going to talk about and really focus on are the GI origins, or appendix, colorectal, and gastric. And so really, what is the clinical problem? Is that in the primary disease, they're very rare, and the survival is pretty low from them. In the natural history of disease, if you let them treat, it was only about 12 months. But the secondary peritoneal dissemination is often equated with systemic disease or metastasis of the tumor that has started in one place and now has spread to another part of the body. Unfortunately, systemic therapy has different efficacy for peritoneal cancers as they do for other sites of metastasis. And when we think that there's limited penetration, or the chemo just doesn't get to these tumors as well, which is a problem when you treat them with chemotherapy through the IV. And the survival from these cancers is quite poor. If we let them go untreated, patients with colon cancer that has spread to the peritoneum, the median or the middle overall survival is only about 5.2 months. Gastric cancer is about 3.1 months. And pancreas cancer is unfortunately about 2.1 months. And so if we look at patients that had peritoneal metastasis from colorectal cancer, when we look at the peritoneal metastasis compared to the other sites of disease, such as the lung or the liver, these patients tend to do worse. Where if we look at the survival of patients with lung metastasis, it could be about 25 months, liver metastasis 19 months, and peritoneum with best systemic chemotherapy about 16 months. So these patients do worse than other sites of disease. So why does this happen? Is that we think that the tumors shed through the wall from big bulky tumors. So the tumor cells kind of break off. And you can see from this study that patients with a larger tumor that pushes through the wall of the intestine, that these cells get shed off into the peritoneal cavity, and then it flows through the peritoneal cavity with the flow of the fluid within the abdomen. The abdomen normally has some fluid, so the intestines can move around on itself. And then when the flow of this fluid goes around, it disseminates these cells through the abdomen. So how do we treat patients with peritoneal surface malignancies, and what is our goal? So you could pretty much break it down into, what are you trying to do? Are you trying to really, is it treatment or is it palliation? And now some folks would argue that all we're really doing for patients is palliative surgery, but I think what we're really doing is treating them and helping prolong survival. And how we treat these patients really depends on the extent of disease within the abdomen. So the disease can go from just cells, where we don't even see visible disease, but we look at the fluid that's in the abdominal cavity and you can just see cells there, versus minimal disease, which we see on the top right, versus more widespread and very high burden of disease, which we see here on the bottom two pictures. So what I believe is the best outcomes come from multimodal therapy. So giving patients a combination of IV chemotherapy along with surgical resection. And then I'm a big proponent of surgery with chemotherapy, or giving the Hipec therapy. So what is cytoreductive surgery and Hipec? Is I basically think of these as two separate procedures, both done at the same time. So cytoreductive surgery is removal of all the tumor that we can see in the abdomen, so removal of all visible tumor, while Hipec is the warm chemo bath. So we close up the belly and we perfuse the chemotherapy through the abdomen. And I think of this as to take care of the disease that we do not see, or the microscopic or on the cellular levels, as we saw on the previous slide. And I want to make a distinction when we're talking about these GI cancers, that cytoreduction just doesn't mean debulking. For the most part, when we talk about patients with gastrointestinal malignancies, is we want to remove all visible tumor and not just some of it. Because what we see is that what we want to do is get all visible tumor less than 0.25 centimeters or 2.5 millimeters. So we think that the chemoperfusion can help take care and clean up the rest of the disease that's less than this. So we consider that removal of all visible tumor. So how did we get here? How do we kind of come up with this treatment strategy? And the idea of cytoreduction or tumor debulking is not new. This was conceptualized almost over 100 years ago with Dr. Meggs here, who's a GYN oncologist. And then we discovered that if we use certain types of chemotherapies, we can keep these chemotherapies within the abdominal cavity, so we don't have the leakage to all other parts of the body. Is that when we treat with the Hipec therapy, it's a very localized therapy within the abdomen. It's not treating all parts of your body, it's staying right there locally within the abdomen. And then really in the 1980s, Dr. Sugarbaker was looking at investigating the use of cytoreductive surgery in Hipec for these gastrointestinal cancers. And what he found is that you can give heated up, warmed chemotherapy in the abdominal cavity with good peritoneal concentration without it leaking out into other parts of the body. So what do we look at, or what are variables and considerations to do cytoreductive surgery and Hipec? So the one thing for cytoreductive surgery was when we look at how much tumor is there. So what we look at is a scoring system, which we'll talk about in a second, called the Peritoneal Carcinomatosis Index, which allows surgeons and other medical doctors to discuss with each other about how much disease there's in the belly, and also our ability to completely take out all the tumor, the completeness of cytoreduction. And then when we talk about Hipec, things that we consider is that what temperature we're doing it, how long we're doing it for, the technique we're doing it, and also what agent you're using, or what chemotherapy are we putting through the body. And so this is what we talk about when we talk about the Peritoneal Carcinomatosis Index, also known as PCI. And basically we split the belly up into 13 different regions, and we make a scoring system of 0 to 3 of where tumors involved. And that's how we really are able to talk, communicate, and help our decision making in the operating room of whether we should proceed with cytoreductive surgery and Hipec. And really, patient prognosis is very closely linked to our ability to take off all the tumor. So if we look at this study, patients that were able to undergo a complete cytoreduction did much better than patients that had little visible tumor left behind. So How do we do a cytoreduction? Again, the goals is a complete cytoreduction or take away all visible tumor less than 2.5 millimeters. So this can often be a multivisceral organ resection. Some folks refer to this operation as the mother of all surgeries, because when you're going in for a cytoreduction, you have to remove all the tumor from the abdominal cavity. And sometimes in order to do that, you have to take out parts of the stomach, the small intestine, the colon, rectum, pancreas, spleen, parts of the diaphragm, parts of the surface of the liver, the uterus, the ovaries. And I always take out the omentum in these folks because it can harbor disease, or you can have microscopic disease within the omentum that you don't see. And also it can kind of plug up the catheters when we do the Hipec later. So I always take out the omentum, which is also the fatty covering over the intestines, and then do a peritonectomy or remove the abdominal lining as needed. So how do we determine who's resectable? It's basically what can come out and what can't come out. So it's our ability to achieve a complete cytoreduction. If you have diffuse small bowel involvement, you can't remove all of your small intestines, so that could be a burden to achieving a complete cytoreduction. I generally, in folks that don't have gastric cancer, want to preserve the proximal third portion of the stomach, because folks just don't tend to recover very well after a complete gastrectomy for, say, a different pathology such as colorectal cancer, and also major involvement of the porta hepatis, or where all the big blood vessels go into the liver. It can be quite hard and challenging and sometimes dangerous to clear this if it's densely involved with tumor. And so if you can't take out all the tumor, you're not a candidate for cytoreduction. And then this is what the Hipec looks like. So we have temperature probes that go inside the abdomen on our inflow and outflow catheters, and the fluid and the chemotherapy goes around a circuit, and so it comes in through one of the catheters where it perfuses around the abdominal cavity, and then it goes out the other side, and it goes again through a warmer into a circuit that bathes the abdomen in chemotherapy. So why do we do intraperitoneal chemotherapy with the Hipec? Because again, we can increase the concentration of drug with limited spillover into the abdominal cavity, and this also is really limited by tumor depth. So that's why we can't just do Hipec for big, giant, bulky tumors in the belly, is that it penetrates about that 2.5 millimeters or 3 millimeters into the tumor. And then why do we heat it up? So the thought is when you heat up the chemotherapy, you can increase cell membrane permeability, allow the chemotherapy to work. It can change in the transport mechanisms and the cellular metabolism of the cancers, and it can really increase the tumor penetration. So if you look at, there are different methods by which we can do intraperitoneal chemotherapy. Probably one of the most known is the Hipec, or the heated intraperitoneal chemotherapy, but other things that you might hear of is NIPEC or EPIC, or the normal thermic. So we're not heating up the chemotherapy, it's given at normal temperatures. The EPIC is an early postoperative intraperitoneal chemotherapy, often given with catheters that remain into the abdomen after the time of surgery. And there's also a new emerging therapy called PEPAC, which is pressurized intraperitoneal aerosolized chemotherapy, which is done in a minimally invasive fashion, where you put catheters inside the belly, which blows up with air, and the chemotherapy is aerosolized. So who are really candidates for this? And one of the methods I use is a diagnostic laparoscopy, or putting a camera inside the abdomen to take a look at what's going on. Because when you look at patients with peritoneal cancers, how I like to describe it to folks is, if you're sitting in a room, is that you might not, and you're looking at the room from bird's eye level, and you're looking down upon it, you might not see things that are flat on the walls, like picture frames or posters, but you'll see big bulky items like a desk or a chair. And so what I'm really looking at is not only of the big bulky things, but things that might not be visible, like the posters on the wall. So a diagnostic laparoscopy really helps us determine the extent of the disease. And what we found is, if you have a PCI greater than 20, or you have a high burden of disease, your ability to achieve a complete cytoreduction is pretty low. So those patients, we want to take pause and really think of what, if we're going to do, is going to really help you. And again, this helps us determine the burden of disease if the small bowel is involved, the stomach's involved, and the porta patas. So things that we talked about earlier of what can help or what can be seen to resect all the tumor. So who are candidates? Kind of how I look at it is what is the extent of disease, what's the resectability, what's the patient's overall health, so are you able to tolerate a major operative procedure, and what's the tumor biology? Is your tumor progressing very rapidly? Have you responded to chemotherapy? Is the tumor going through chemotherapy rather fast? And if all of those look favorable, then you'd be a good candidate for a cytoreductive surgery in Hipec. Other important factors that we look at is really what is the biology of the tumor. So there's a saying in surgical oncology that biology is king. So where's the tumor coming from? Again, what are the histologic characteristics? Does it look poorly under the microscope? How fast it's growing? Is it a penetrating versus pushing tumor? So if it's on the CT scan, does it look like it's growing into organs, or is it pushing them around? Again, your response to chemotherapy in the past, and is there tumor outside the peritoneum? This is one of the other important thing is that the peritoneal disease or peritoneal metastasis is one type of metastasis that you get. And we really have to think long and hard that if you have disease in the liver or the lungs, is treating the peritoneum locally with a disease or with a therapy such as cytoreduction, Hipec, really going to help if we have disease outside. So that's a very important factor, but it's not a definite no, but it's a second guess on what we're doing. Is that really going to help you? So who do we do this on? So we look at appendiceal tumors. There's multiple different types of appendiceal tumors. We'll go through these a little bit later. Colorectal cancer, it's been quite controversial, the use of Hipec in addition to cytoreductive surgery. Gastric cancer, again, a bit controversial, but it has made its way into the current NCCN guidelines. And we'll talk about that a little bit later, as well as mesothelioma. So if we talk about, we'll start with a little bit about appendix cancers or appendix neoplasms. So one thing you might hear of is a lamin or a low-grade mucinous neoplasm. So this is not cancer. So these are patients that have a neoplasm or an abnormal growth within the appendix. And these patients also can get what we call a pseudomyxoma peritonei, also known as a jelly belly, where they get the abdomen filled with fluid that's almost like a mucin nature. And how we treat this is basically how much is in the belly, whether it's contained, whether it's ruptured, but these patients can make a good candidate for cytoreduction and Hipec. And similar to lamin, which is a low grade, you get a Hammond, which is treated very similarly. But then when we go into the cancers, we want to look at the use of chemotherapy in addition to cytoreduction and Hipec. And again, this is largely dictated by how much disease you have, if it's widespread in the abdomen, and a lot of this is driven by patient factors, as well as your adenocarcinoma, which is what you normally think of when you think of your standard colon cancer. And these patients in the appendix, we're starting to learn, are different from colon cancer, but we generally all treat them the same, and these also can be a good candidate for cytoreduction and Hipec. But again, it really depends on your burden of disease and how much of a cytoreduction you're able to achieve. As you can see here, patients with less disease with a complete cytoreduction do better than people with a high burden disease and an incomplete cytoreduction. Other cancers you can get of the appendix is something called a goblet cell cancer. Now, a goblet cell cancer, I like to explain to patients, is a mixture of almost an adenocarcinoma of your standard colon cancer type pathology that most people think about, and a neuroendocrine tumor, or a more rare cancer. And these patients are also can be treated with cytoreduction therapy and Hipec, but this is also largely depends on your burden of disease, where the disease is, and also how aggressive your disease is and how it looks under the microscope. So moving on to talk a little briefly about colorectal cancer and peritoneal metastasis. So I think the one thing that we can say about treating patients with peritoneal metastasis from colorectal cancer is that cytoreduction works, and that if we look again, patients with peritoneal disease treated with best chemotherapy, median survival is only about 16 months. But if we're able to take out all the disease or take out all the tumor within the abdomen, regardless of giving Hipec or not, we can increase that survival to around 41 months, which is a significant change. So what's the data specifically around doing Hipec for these folks? So this was a study done in 2003 that looked at Hipec for standard of care chemotherapy, and what it showed that Hipec actually increased survival in these patients and made them live longer. This study is a bit controversial because this was done before what we can now consider modern systemic chemotherapy, or what you might hear about FOLFOX, or introducing oxaliplatin to patients systemically. So this study is kind of now looked upon a little unfavorably. And the other study, which we might hear of for colorectal cancer, is PRODIGE-7, which came out within the last couple years. And what it did is looked at patients that received cytoreductive surgery alone to cytoreductive surgery plus Hipec. And what they found is that the addition of the Hipec did not increase patients' survival. So it didn't make people live longer. And one of the things to note about this is that they used oxaliplatin with these patients, and it was given along with IV chemotherapy, or 5-FU. Now, about some criticisms of this study is about half of patients already received oxaliplatin therapy beforehand, which might think that if you're already treating a tumor with something, is that tumor already used to it, and those patients are not going to respond in the same way. Other things that they found in a subset that in patients with a PCI, or a tumor burden between 11 and 15, is that they might do better with Hipec therapy. So in my mind, that questions on, is it just about selection, where in some patients, if you remove all the tumor, they do good enough, where in other patients, no matter what you do, might not work. So I think there's still a lot of questions to ask about the utilization of Hipec in patients with colorectal cancer. I still do perfuse patients. I use mitomycin C. So in the United States, compared to the study which was done in Europe, we use a different agent. In this study, they use oxaliplatin for 30 minutes. I use mitomycin C for 90 minutes. So again, choice of agent, length of perfusion, previous oxaliplatin exposure, and patient selection. So all of this still factors in. So I think no matter what surgeon you have, it's good to ask about it. And I think there's still controversy and still questions that need to be answered around this. But there was another study that came out about a year and a half ago called the Hipec T4 study, which actually looked at giving prophylactic Hipec to patients. So patients that looked like they had big bulky tumors, or like we were talking about before, the tumors that have spread kind of through the wall of the colon. And we know that these people are at increased risk. So this study looked at doing a Hipec prophylactically without patients with peritoneal metastasis. They used, again, mitomycin C, and what was found is a significant improvement in 3-year local recurrence. So patients that had the Hipec had a decreased rate of developing peritoneal metastasis, but this did not translate into an overall survival benefit. So even though that the disease didn't come back in the abdominal cavity, that it didn't help patients live longer. This is not yet prime time, meaning we don't standard do this, but I'm curious over the next couple of years how this will make its way into our treatment algorithms and what we're going to do for patients. Because my thought is that peritoneal metastases are very difficult to treat, not just in survival, but also in symptoms. And I think it'll be interesting to look at maybe follow-up from this study in the future, which might help it incorporate into guidelines. So again, some takeaways for colorectal cancer is that the use of Hipec in addition to cytoreductive surgery is debatable, but I don't think it's debatable that cytoreduction helps patients that have colorectal cancer. And now moving on to gastric cancer. This is a study that looked at doing a gastrectomy in the setting of metastatic disease. So you're not taking out the metastatic disease, you're just taking out the stomach versus chemotherapy alone. And what it found is that the gastrectomy does not offer you any survival benefit. So some folks are wondering why we don't do a gastrectomy in the setting of metastatic disease. If you're not able to clear all the disease, it doesn't make you live longer. But what we also looked at is if you did cytoreductive surgery alone versus cytoreduction in Hipec in these folks, is that the Hipec does confer a survival benefit. Now, this is a bit of an older study, but what we're able to find is that if you're able to clear all the disease and do a Hipec, this study used mitomycin C and cisplatin together, that you're able to increase your survival. But I do want to note, we want to look at what the survival actually is, and in both arms is still pretty poor in this study, 11 versus 6.5 months, so still less than a year. So it gives about additional 5 months on this study. And then what do we really want to do is that what we know with gastric cancers, the PCI really matters. I believe compared to all the other diseases that we talked about before, appendix, colon, is that gastric cancer PCI really, really matters. And if you look at this study, which was published back in 2010, patients with a PCI above 19, there's no people living over 6 months. So I think it's really about, again, selection and doing our best to help select patients and ultimately not hurt anybody. So these are some of the current treatment strategies. So I think that one dose of IP chemotherapy with gastric cancer is probably not enough. There's two different kind of thought processes, as if we can give normothermic intraperitoneal chemotherapy through catheters and kind of downstage disease, or kind of get patients that we know the disease is controlled within the peritoneal cavity, they might be candidates for cytoreductive surgery and Hipec in the future. Or what also often is done, and what I do is repeat Hipec. So try and see, can we control the disease? Can we push that PCI down? Can we control it and kind of see how the tumor is behaving? And this was a study out of MD Anderson, and kind of is exactly what they did. And they looked at doing at least one laparoscopic Hipec before they would do any gastrectomy, and that a lot of patients in this had a PCI less than 3, so very, very low disease, and they were able to get a overall survival about 22 months, which is almost double of what we saw in that study from 2010 that we talked about. And this is a follow-up study that they did that looked at laparoscopic Hipec without cytoreductive surgery, and the patients that really had the peritoneal disease resolved went on to get gastrectomy. And they were finding this very select patient population, they were able to get a median overall survival of about 30 months compared, and about 20 months from the first Hipec. So I think this is encouraging. I think we still have a lot of work to do in this space, and kind of our takeaways from this, and what I tell folks is wait, and really it's all about selection. It's selecting the right people for it. It's making sure that the disease declares itself, because what I don't want to do is do an operation or give you a therapy that's not gonna fix the problem. And a little bit about peritoneal mesothelioma. So if you look, if anybody watches daytime television, you see a lot about the asbestos exposure. So this is related to pleural mesothelioma, but what we know is it's not exactly the same. And how we treat folks with mesothelioma of the peritoneum or of the abdominal cavity, it's really dictated by the biology and what kind of tumor you have. So it can come in kind of 3 different variants: epithelioid, sarcomatoid, and biphasic. The epithelioid are the better behaviors, or they are less aggressive than the sarcomatoid, and the biphasic kind of sits in the middle, and it's a mixture of the two. And kind of how we treat is really kind of can depend on the mixture of cells that are there. And this is just a complex treatment algorithm that we use to help make decisions. And in general, if you have a biphasic or sarcomatoid or bicavitary disease, you're often getting systemic chemotherapy, where if you have confined disease with a better variant, those patients can be good candidates for cytoreductive surgery and Hipec. And I think it's very important, not only for surgeons or for medical oncologists to know about what cytoreductive surgery and Hipec is, because I think this can really help people. This is a study that I did several years ago where I wanted to see how many patients actually see a Hipec surgeon. And this is from a large database called the SEER database. And we looked at specifically patients with colorectal cancer, and we saw that only about 6.4% of patients saw a Hipec surgeon. So very, very few people are actually referred to a Hipec surgeon. So I think it's important for people to know about this therapy and that this exists, because we found in the same study is that people that underwent cytoreductive surgery and Hipec did better than those patients that received systemic chemotherapy alone. So my takeaways for this talk are really peritoneal metastasis are common, and that treatment options are available. So I think that we can help a lot of patients by doing this therapy. This is my contact information. I see patients throughout the New York area. I see patients ranging from downtown Manhattan to Nassau County in Long Island, all the way out to Suffolk County. So I'd be happy to take any questions if anybody has any at this time. Glenn, you're muted.
Dr. Brown, there are some questions coming in. What is the difference between oxaliplatin and mitomycin C, and how could these differences affect patients' outcome?
So it's just different chemotherapies. They have different mechanisms of action of how they work within the cell on the cell cycle. So it's just about the different drugs. It's like giving different chemotherapies, and different chemotherapies can have different efficacies on cancers. And I think one of the things that is coming through the pipeline that people are looking into is even testing cancers for chemotherapies, or making what we call organoids, or making little cancer balls to be able to test to see which chemotherapy actually works for your specific tumor. So I think that's kind of where cancer therapy is headed, is not just everyone gets one bland therapy. If you have colon cancer, you get this medicine. If you have gastric cancer, you get this medicine. I think it's really, how can we treat patients on a personalized level? And so a lot of this is done is through retrospective data. We don't actually have head-to-head studies looking at perfusing patients with oxaliplatin versus mitomycin C. A lot of it is unfortunately retrospective, and we kind of just use the information that we have. But that's the difference between the two. It's just different chemos, different ways that they work. But we do pick chemotherapies that will stay locally in the belly and not perfuse over.
Another question coming in: do patients with gastric or colorectal cancer have a lower chance of being candidates for Hipec?
So I think it's all about disease biology. So I'm a little more careful with patients with gastric cancer, because as we went through those studies, patients with gastric cancer that do have a higher PCI or a higher tumor score, patients over a PCI of 19, they do just very poorly. There are certain patients with either like appendiceal or colorectal cancer where you get up to 19 and you can still clear them, that I would consider them candidates. So that's why I really believe in the repeat Hipec for gastric cancer specifically, is can I get the disease burden down and test the biology of the tumor before we go ahead and do a big operation. So I hope that answered that question.
Along the same lines, another question coming in: is Hipec still worth looking into for patients with a PCI over 20?
I think it depends on what disease it is. And I think that's the most important thing is what disease you have. So if you have gastric cancer, if you have colon cancer, and also really what your response is to systemic chemotherapy. So we can downstage some patients with systemic chemo, where I've seen that if you get a good response and the chemo does work very well, I never say absolutely not to anybody. I always think it's worth, even if it's putting a scope in to let you know. I think that's very helpful, and I've done that many times where people have a good response. So what do I consider a good response? A lot of times with patients with peritoneal metastasis, their belly fills up with fluid. Now we talked about that the belly makes fluid naturally, so your intestines can rub against each other and you can digest your food. But what happens is if the lining of the abdominal wall is all covered with tumor, you still make fluid, but you can't absorb it. So you can fill up with a lot of ascites. And I've seen a lot of patients where they get systemic chemotherapy and that ascites level goes way down. Is that they go from getting a lot of liters, so like 4 to 6 liters drained every 2 weeks. Then all of a sudden they notice they're getting chemotherapy and they're getting it drained once a month. And then they're getting it drained every 2 months. So I think that's very, very promising. And I tend to be more aggressive and try and put a scope or a laparoscope back in these people to see, can we actually do a complete cytoreduction, and if they'd be candidates for Hipec.
Okay, another question coming in. Are there any current future studies being done on gastric and colorectal cancers, plus Hipec to update the results?
Yeah, the one thing is that there's a lot of effort now to try and get people all playing in the same sandbox and to really push it forward to get these big multi-cooperative group studies going. So there's several in the pipeline. I think the most exciting data is coming in gastric cancer, and what I really hope for too is what's the use of Hipec, or the pressurized aerosolized chemotherapy, because I think that's still a large unknown, and I think that's exciting data that's going to be coming out of there soon. That therapy is offered a lot more in Europe and is really just starting to make its way to the United States.
Another question: if the disease is recurrent or comes back, these patients, can repeat Hipec be done?
Yes, a repeat Hipec can be done. It can be done safely, and I think it all depends on the burden of disease. And I think one of the other important things is what's the time frame that it came back? Did it come back right away, or did it come back in a delayed fashion and years later down the road? If it comes back almost immediately, I would not offer another cytoreductive surgery in Hipec, where I have done multiple Hipecs on folks where it's come back many years down the road. So that is an option.
Okay, last question is, what sets the cancer treatment at Hipec program at NYU Langone from the others?
So I really think it's our multidisciplinary team, is that I don't make decisions by myself, and I don't think that's how cancer should be done, and that all these patients are really talked through in a very thoughtful fashion. And I think no matter where you get treated, that's kind of how it needs to be run, and we make decisions for very complex cases on a very individual or personalized level, where some patients we see they'll be candidates for a cytoreduction in Hipec, where patients with a very similar disease presentation won't be candidates for a cytoreduction in Hipec because of very thoughtful discussions, not only with the surgeons, but also the medical oncologists and the pathologists, who really lead the discussions on trying to do what's best for the patient, and not just to try and take all the tumor out, but to really look forward on should you get chemotherapy first, should you get surgery first, do you need a combination of the two, and I think that's what really sets us apart.
Dr. Brown, there are no more questions coming in. I want to thank you for the great presentation, very, very thorough presentation, and I'm sure this has been helpful. Thank you very much, and I want to thank our audience for attending also. Have a good evening.